Thank you. Thank you very much. Okay, so I'm going to talk about the HVTN 702 trial results. And the scope of my talk will be to give you a bit of background, the trial design, the results, and some other additional sub-study findings, as well as the conclusions as to why this trial failed. So just to give you some background, in 2009, we heard that the RV144 study conducted in Thailand demonstrated efficacy at 61% at 12 months, and there was waning durability, and this was reduced to around 31% at 42 months. Based on this data, a POX protein public-private partnership got together and oversaw the development of a modified POX protein vaccine program, which was aimed at trying to look at whether we could replicate the efficacy of the RV144 study in a part of the world where there was a great global subtype C predominated. And we also wanted to see whether we could increase the durability of the immune response, and also evaluate whether the V1, V2 IgG, which had been demonstrated as a correlative risk and vaccine efficacy in RV14, was translatable to HVTN 702. So this was a 2B3 multi-centered randomized double-blind placebo-controlled study of the LVAC pox vector together with a bivalent subtype C GP120 adjuvanted with MF59 in HIV uninfected adults in South Africa. There were 5,400 subjects. Participants got the LVAC prime at months 0 and 1, and got the boost at which was the LVAC together with the protein C at months 3, 6, 12, and 18 months. We did amend the protocol to give an additional boost at the 18th month time point because we saw some durability issues following the immunogenicity of HVTN 100, which was the phase 1 counterpart that gave us the go-no-go criteria to go ahead with HVTN 702. We did HIV tests every 3 months for a maximum of up to 36 months. So the two regimens were different, and I'm just going to show you the difference between the two studies so you can see. There was a difference in the LVAC vector. As you can see, we adapted it to be more clade C specific. There was a difference in the protein boost. We modified the protein boost from a bivalent subtype BE to a bivalent subtype C using 1086 and TV1. The protein dose was different, as well as the adjuvant. The RV144 had alum, and we used MF59 in 702. The population was also different. The Thai study was a community-based study with low-risk population, so people had low risk of HIV acquisition, whereas in South Africa, we focused on a high-risk population, heterosexual women and men. The epidemic in Thailand at that stage was generally low incidence in the population, and in South Africa, we have one of the world's largest epidemics, particularly in young women. So the primary objectives were to assess the potency of 702, and this we did at the 24-month time period, and obviously the tolerability as well. We also had a secondary objectives, which was to see whether the vaccine was durable up to 36 months, and also to evaluate the impact of the full regimen on early efficacy as characterized at 6.5 months, which was after the sixth time period, and up to 24 months, which is the early efficacy. And we also wanted to see whether there was a difference of vaccine efficacy on different demographic characteristics. So these are the trial sites that we used in South Africa. We enrolled from October 2016 to June 2019, and we had a huge geographical spread of trials across the country of South Africa. This just shows you the schema where we screened over 10,000 people, enrolled over 5,500 people, and randomized into vaccine and placebo. This shows you the modified intent to treat cohort, as well as the participants who were HIV negative on study at month 6.5 and who were evaluated thereafter. In terms of the randomization, this worked very well. We saw similar distribution by participants between vaccine and placebo arms by sites, sex at birth, gender identity, median age, race, full blood counts, body mass index, male circumcision, the type of contraception women were on, genital tract infections, and self-reported risk factors. Overall, and most of the participants in the study identified as heterosexual and were evenly distributed across the study groups. You can see our retention was very good, and this shows you the loss of follow-up over time in the study, and you can see there was no difference between vaccine and placebo. We had regular DSMB meetings during the trial to evaluate the data, and in January 2020 this year, the trial met the non-efficacy criteria after sufficient follow-up at month 18.5, which triggered an ad hoc DSMB meeting. At this meeting, it was found that there was no difference between vaccine and placebo. And here you can see the HIV incidence between vaccine and placebo in the modified intent to treat, which is from month 0 to 24. The placebo and vaccine incidence were the same, around 3.4%. In the women, in the MITT, from 0 to 24, you can see there was very high rates of HIV incidence in the placebo and in the vaccine arm, and in the men, low rates, overall incidences of 1.3%. So what this slide shows is, first of all, that the vaccine was futile, but also demonstrated again the high incidence of HIV in women in South Africa, showing that HIV incidence hasn't changed in South Africa despite having one of the largest treatment programs in the world. This Kaplan-Meier shows you the difference between placebo and vaccine over time, looking at months 0 to 24, and you can see there's no difference between vaccine and placebo arm. And this just shows you the durability also. We did not see any difference in the long-term follow-up and evaluation of the vaccine regimen. And this shows you in the month 6.5, so people who were HIV negative at month 6.5 to 24, you can see that there was no difference between vaccine and placebo. So we saw no difference in subgroups when we looked at when we evaluated the vaccine effect by sex at birth, age, baseline HIV risk score, and body mass index. We saw no difference between vaccine and placebo. Just in terms of safety, this was generally safe and well tolerated. Some more reactogenicity in the vaccine as compared to placebo, but the adverse events were balanced between the groups, and rare adverse events related to study product were slightly more in the vaccine arm as compared to placebo. We had a few related AEs that resulted in vaccination discontinuation, and these were usually rash, urticaria, cellulitis, diarrhea, and headache. We had 18 deaths in the study, and these were not related to study agents, and they're mostly attributed to trauma and violence, which is quite endemic in South Africa. And then obviously no congenital abnormalities seen in the 163 pregnancies. We had a preamble study, a phase 1 study, HVTN 100, which was the study done to evaluate the go-no-go criteria for our advancement into this late stage efficacy study. And the HVTN 100 showed very good immune responses. We saw very good binding antibodies. We saw ADCC to GP120, GP140 antigens, and good T cell responses to vaccine-matched peptide pools, which were of greater magnitude in this phase 1 study as compared to the RV144. However, we did the V2 loop responses were always higher in the RV144 study compared to the HVTN 100 study. So what were the reasons why the study was futile, and why do we think there was lack of efficacy in 702? It could be due to immunogenicity differences, which may have arisen from the differences in the LVAC, the protein, the dose, the adjuvant, and additional boosters. So these were not the same vaccine, and they were highlighted earlier on. These were different vaccine regimens, And obviously the difference could have been because the vaccines were so different, and that's why we didn't see we saw lack of efficacy in 702. There could have been issues with viral genetics. We had probably saw much higher viral diversity in South Africa, and a much higher likelihood for the vaccine sequence to mismatch relative to the circulating strains, which then obviously led to a lack of efficacy. There are host factors that could have been an issue, potential differences in pre-existing immunity, mucosal inflammation, the microbiome, or different genetics or FC receptors and HLA. We think that a lot of the differences may also have been due to HIV exposure. We saw a very much a higher, more viral load and more exposure to HIV in South Africa as compared to Thailand. And possibly the difference, the possibility it could have been that there was just a high threshold of infection, which was impossible to overcome. And possibly the huge differences in the vaccine regimens may have contributed to the issues around lack of efficacy. So what are we going to do, and what's going to happen with the correlate study? So obviously we are interested into understanding whether there were any subpopulations that may have been where vaccine efficacy may have worked. And there will be a analysis study and a limited case control study. And this will basically be to evaluate whether vaccine efficacy depended on any genotypic characteristics of the exposing HIV virus, and to assess whether there was any immune pressure from the vaccine on HIV sequences. The limited case control will assess the immune response biomarkers in vaccine recipients as correlates of HIV risk, and we'll also assess key vaccine-induced immune responses, and in focusing obviously on the RB1144 correlates of risk to try and understand what went wrong. And these are obviously very critical studies to be done to try and understand the lack of efficacy in 702. We've done some other studies just looking at some sub-studies in 702 at one site, and we found, just looking at prevention methods in our subjects, is that that condoms were well known as a method of prevention, but not preferred. And I think we need to consider other issues. We did provide PrEP for free at the sites, and we also did provide the monitoring for free of PrEP. And so I think that we had very low PrEP uptake in the study, and obviously it's important to look at other innovation for HIV prevention, such as long-acting injectables, as well as the use of passive antibodies and other HIV prevention technologies. And obviously what we do need in South Africa is a prevention method that's long-lasting, is discreet, and can blend into a user's lifestyle without it being too obvious, given the our patriarchal society and the high rates of gender-based violence. So there is a huge gap in biomedical prevention in South Africa, which aim to reduce sexually acquired HIV in South Africa. So in conclusion, HVTN 702 regimen had no prevention efficacy. And despite standard of care and the availability of PrEP, HIV incidence was high in our study and is high in South Africa, especially in young women. We do need and need to explore a biomedical intervention that can help women reduce HIV acquisition. I'd like to thank all my co-chairs, Fatima Leher, Linda Gale-Becker, and Moho, as well as all the study participants and all the site team and everyone who worked very hard to get the study done. Obviously, it's very important to always acknowledge our funders, because without them, we would not have been able to do the study, and particularly the NIH and the Gates Foundation. It's so important to also acknowledge the HVTN and SHARP data management and statistics, as well as the CABS communities and stakeholders. These are the sites that were involved in the study, and we just want to acknowledge them as well and thank them for their participation. Thanks very much.